All right, let me clarify some things real quick for the rest of the semester. So today, I'm going to try to finish. Hopefully, it'll only take me about an hour. But tomorrow you have arthritis and gout. Dr. Mercer is going to come in and teach arthritis and gout. Your test is going to be on the 17th, so I'm going to start working on your test. You still have memory jogs, all of the things. This is my last block teaching you guys, and then you will have, you guys are going to like Dr. Mercer. He's really awesome. Like, I got to pick who was helping me. And so what's going to happen, you'll still have the memory jogs, you'll still have the same types of exams. I will still be reviewing the exams. And so he's going to teach the last 2 blocks that you guys have for Pharm. Okay, so you still have the same things, same principle, like the schedule, all of that stuff. He has everything that I have done. We have revamped the slides, so you guys are going to be okay. So y'all will have him for the last 2 blocks, okay? So a lot of the things that we talk about in this block when we're looking at arrhythmias are the things that you're going to see on your next block with him. Some of these things, you're going to see them come up again, okay? So just be mindful of that. If you need me, you can text me. I won't be around here because I'm traveling a lot. So just let me know if you need help with something. All right, finishing up with this. So we were talking about digoxin. We were saying that this one was very good with rate control. We were saying that it's an old drug. We use it, very rarely will you see it used on its own. It's usually to kind of like help us further manage someone who's having symptoms with some type of tachyarrhythmia. But it is a good drug, old, not something that we love because all of the monitoring parameters and all the things that we have to do when we're talking about digoxin. But PANTS, my pharmacy test, any test, they love to test about digoxin. Nursing tests, they talk about digoxin all the time too. So like, please be familiar with digoxin because you are going to see digoxin come up with me for sure, but also on potentially your PANTS. So looking at my contraindications, I thought I didn't have it on the slide and I had it on the slide, right? So I told you so when we talk about VFib or ventricular fibrillation, you can also hear it as VFib. This one is a contraindication and I will just list it this way. You will learn more about that in cards. If they have heart block or their heart rate is less than 60, that was what I was telling you guys to write in, but it's there. We already talked about hypokalemia and if that is off, how it can mess up the mechanism essentially of the drug. So remember our mechanism of action, we had that sodium, potassium, ATPase exchange that was happening. So my potassium was down, my sodium and my calcium were going up in the cell and that was giving me that good cardiac output, that good contraction that I needed to happen. So if I have hypokalemia, I'm not going to have the correct exchange that I need to occur and therefore now you're also messing with the mechanism of action of the drug. So you need to correct, if there is a potassium disturbance, you need to correct that prior to you trying to give them digoxin. And then WPW or Wolff-Parkinson-White syndrome, this is essentially where there's another escape route, like I was telling you about our rhythm. If we're trying to get a pulse down or a signal, our body gets very creative and it can create other routes in which they can do that. So this is another contraindication that you have. Your electrolyte levels of digoxin. So when we look at this, we have our potassium competing with digoxin because of our mechanism of action, right? The sodium, potassium, ATPase, right? So if I look at someone who has hypo is low, hypokalemia, you're going to see now digoxin has increased binding. There's nothing there for it to compete with, right? It's low. They have low levels of that potassium, which is normally what it is trying to compete with, okay? So hypokalemia, increased digoxin binding, and now I have enhanced effects of my digoxin, which means more side effects, more issues. Now the drug is working better than I need it to work, okay? So these are all of the signs that you will see in those situations because of the increase of efficacy, essentially, of your digoxin happening. So muscle cramps, their heart rate might speed up because I could trigger tachyarrhythmia with this, seizures, confusion, so lots of things that are not fantastic when we talk about DIG and the side effects of DIG. Here, this was again something that we saw when we talked about the CASH trial, right? We talked about us looking at our 1C drug. You can see that we have also found that arrhythmias can be, or digoxin could be pro-arrhythmic, okay? So increasing that risk of sudden death with this drug. So that is why hypokalemia is a contraindication, and we would need to fix this or find the underlying issue for this first before we're trying to give them the digoxin. And then hyperkalemia, now you have the opposite. Because I have so much potassium, right? Now my digoxin is like, let me in, let me help. Can I do my job? But there's so much potassium there that it can't. And so now the effects of digoxin are decreased, okay? So hypo, low, and now I've increased the effects of my digoxin. Hyper, high. Hyperkalemia, I have a lot of it, and now digoxin has to compete with it, and therefore I'm not getting the great response that I wanted to get from my digoxin. Okay, so now you've added on a drug that could cause these side effects that may not be super beneficial for your patient because they have hyperkalemia. So again, something that we would need to correct. So understand what's happening in those two situations, and that your hypokalemia is an actual contraindication. Okay? Yes. Do you need to know any information from it? I skipped 2 slides. Did I miss this one? This? Oh, shoot. Yes, thank you. This, yes. No, don't just say non-testable. Y'all didn't even say anything over there. Are y'all listening to me? Y'all just wanted me to skip slides and be like, ma'am, you didn't tell us that. You didn't tell us that. How dare you have a question on it? You said it didn't come out of your mouth. Okay, now this will make more sense. I was like, did I talk to them? But that was yesterday. Yesterday was such a long time ago. Okay, so your adverse effects, right? When we look at our adverse effects, this is what I keep telling you about digoxin and why we're like, the effects of the drug are not, the effects that we get from it are great, right? It can help us get to the symptom control and the management that we want, but the side effects are not good. So your mild are things that we typically can see, right? Nausea, vomiting, I tell y'all, almost all meds, headache, right? Anorexia is something that is kind of unique to this and that you need to watch out for. Hopefully a patient who is this old, most of the time these are older patients who are needing to take these meds, aren't still dealing with an issue like that, but it is possible. Altered mental status and these visual disturbances are the things that your patients will notice almost. They're very aware, like, hey, like things are kind of hazy. I'm not recalling things the same way, or they have this blurred yellow vision. So they can see things, but it has like a yellow tint to the things that they are seeing, okay? So again, that's something for you to counsel your patients on, and that's usually what people like to ask about are the toxicity things that occur with digoxin. So adverse effects, remember, they don't mean that they always have to happen. So these are just things that can happen even within the normal range of you taking digoxin. When I look at my toxicity, these are the things where I have now increased the effects of my dig, or I have given them too much of the digoxin, what have you. Toxicity is too much, whereas a regular adverse effect is just like, it could happen even if I'm taking it within the normal range, okay? So toxicity is anything that's over 2. So I want you to remember that number 2, as well as that range that I talked to you about. So over 2, you in deep boo-boo, okay, is how we try to remember it. This is when things start to happen. This is when those cardiac arrhythmias can be triggered. This is when death can happen if you don't catch it. So there's a lot of things that can happen in this situation that are not great, right? Because we already said pro-arrhythmic when I skipped ahead 2 slides, okay? So your signs that you have, bradycardia, anorexia, nausea, vomiting, all the things, these yellow halos are very important because that is a good sign for them to be able to, like they can't see past the yellow halos, okay? Disorientation, the same thing like I told you, like that altered mental status, and then hyperkalemia. Now, my increased risk of this happening kind of all ties into what we learned in Pharm 1, right? And some of what we learned about the way that this drug works. So My age, we said that usually my renal function declines, right? But also if I have any issues with renal dysfunction, that's going to be a problem because I'm not clearing the drug, which means the drug is just accumulating in my body. I'm not getting rid of it how I'm supposed to. Hypokalemia, right? We talked about that and what happens. Hypomagnesia, hypercalcemia. This is all tied into the mechanism, bless you, and what happens whenever you're looking at intracellularly and extracellularly what digoxin does to these same things, potassium, magnesium, and calcium, right? We talked about what's happening. So with digoxin, make sure that you are remembering where these things are going and what has built up intracellularly and what has went out, okay, extracellularly. And that's all happening because of that sodium, potassium, ATPase, okay? And then you have, of course, several other drug interactions. So if I'm a drug that interacts with digoxin, most of the time it's going to be that we increase the effects or potentially decrease the effects of digoxin. Therefore, I could have, if I'm increasing the effects of digoxin, I could see more of these adverse effects and this toxicity is occurring. All right, drug interactions with digoxin, it's a lot, okay? Decreased absorption. When you look at the decreased absorption, this is decreased absorption of digoxin, okay? So my level of digoxin means now it's going down, all right? Antacids, laxative, cholestyramine, right? These were all things that we said could interfere with any drugs that we could take. So I'm going to separate how I'm taking this medication. Usually we'll do a couple hours before or several hours after to make sure that it doesn't bind or, again, decrease the absorption of those meds. So remembering those. Now, your increase in digoxin concentration. So these are things, right, that you, especially your macrolides and your antifungals, that you as a PA could simply prescribe because somebody came in and they were sick. That can make a huge deal with our digoxin concentration. And I said that as digoxin concentrations increase, we can hit that toxic range, right? Narrow therapeutic index drug. I don't have a lot of time to play around with digoxin. So in this situation, I am very worried, right? So my macrolides that I have, my antifungals that I have, I could potentially see a increase in my digoxin levels, which is meaning I could potentially push them outside of that range, and now they're over 2, and now we have issues, okay? Your class 1A antiarrhythmics, class 2, we see that we have some competition that is happening between your DIG and those drugs, and we saw them on that slide where you can now have an increase in your digoxin level, so we'll try to avoid those. If we're trying to control the rate, usually we'll try to use a beta blocker or that non-DHP calcium channel blocker. There are some times where people might have contraindications as to why they can't use those other two. But we will still try to find other ways before we add on DIG if we can. Hopefully you don't get that deep. If you did get that deep, it wouldn't be your problem. Cards would have to monitor and deal with that patient. They would have to follow them very, very closely. So your class 1A and your class 2 and your dronedarone, we'll talk about dronedarone a little bit more. And then these are just some other meds. We don't go super deep into cyclosporin. We talked about tacrolimus a little bit, verapamil. We've seen that already as well. So again, these are just things that could increase your concentration, and we're very worried about increasing our concentration because that means that I could hit my toxicity. Any drugs, and y'all are going to talk about this next block, but any drugs that affect potassium or that decrease a heart rate. When we talk about that, because of your digoxin also trying to decrease a heart rate, now you have that additive bradycardia that could potentially happen that we've already talked about. So if anything else that you put on board decreases their heart rate, you could potentially see now a very low heart rate in that patient. Again, start low, go slow if there is a situation where you have to do that. It doesn't mean that you can't do it. And then your potassium, again, any drugs that affect potassium. So we have some drugs that will be potassium sparing and increase the amount of potassium that the patient is holding on to. And we have some drugs that are potassium wasting, and that means that now we have made that patient hypokalemic, right? And so anything that deals with potassium, we are worried about it because we already said, where was that one? Now that I got myself all out of order. But we already said anything that messes with potassium, we are concerned, okay? So that leads into this side, which we talked about. and then now your toxicity treatment, okay? So we talked about the halos, we talked about the pro-arrhythmic effects of digoxin. So when we're looking at our toxicity treatment, hopefully you don't get here. Is it a possibility? Yes. So your patient presents, they're coming in, and what was our toxic limit? 2, right? So if anybody that came in and they're over 2, now I'm more worried. What we're going to do is we're going to make sure that they stop their digoxin and let it kind of go out of their body. So usually a couple of days, we're okay. But we also have an antidote, which is great for us. We have Digibind, or digoxin immune fab. And this is an IV that we run to try to bind up, Digibind, bind to that digoxin. So the antibodies bind to the digoxin, and therefore if it's bound, we talked about being bound, if it's in a relationship with my Digibind, now it can't go out in the body and do its effects, and then we get rid of it, okay? So Digibind is binding the digoxin, taking it out of circulation, so therefore it can't work, and therefore now my levels should fall back into range. They're also not taking it anymore, and I can see my patient should start to get better. Those symptoms should start going away, okay? Again, monitoring for that potassium. Now going back up here, when you see toxicity treatment, we'll talk a little bit more when you see insulin. When we start to talk about insulin, we sometimes use insulin to treat hyperkalemia. It'll shift the potassium back into the cells and not have it out into the system. So that's why you see we can use glucose and insulin to treat that. We can also use activated charcoal. It does not taste great. I talked about it a little bit when we were looking at pain. Not fun for the patient. And then if somebody is having a ventricular arrhythmia, of course, you can still use our meds that we talked about already. Most of the time, we'll try to use lidocaine. Very rarely will we see that phenytoin being used for that. Okay, so all of these things that we do in this situation on toxicity treatment can save someone's life when we're talking about digoxin. So all of these have a morbidity and a mortality benefit, okay? So remember what your rescue is for your digoxin is your Digibind. Adenosine. Adenosine is a pretty cool drug. Think about it like a light switch, essentially. So we have this naturally in our body, and when we look at this, you're talking about increasing your potassium going out of your cell and decreasing the calcium that's coming in. And the reason why I say that it's like a light switch is because when you're looking at this, it decreases essentially the heart rate and the conduction, and it resets the heart in a way. So it's a super short half-life. I think that's on the next slide or somewhere. It's very, very short, so seconds. And when you push it, you're immediately following it by a saline flush, because you got to make sure that the amount of drug that we're giving that patient actually gets to their system. If you don't flush it quick enough, because the half-life is so short, it won't do anything. And so the patient will sit there and they're like, was that it? Yeah. Okay, I didn't flush fast enough. Okay, so we'll talk a little bit about it because I got to see this and it was really interesting. So drug of choice for acute conversion of somebody who has a PSVT, paroxysmal supraventricular tachycardia. Okay, PSVT. And so we use it in this situation, and essentially it's just to kind of turn the light switch back on. It's like toot-toot. Their heart is turned off really quick and it comes back on. And the hope is that it goes back into a normal sinus rhythm, or that it starts to beat again, okay? So when we look at this, super short half-life, seconds, right? 6 to 15 seconds, and then we're following it with our push, our saline push. So I don't tell you guys about doses a lot, but this one, you're pushing it, and then, like I said, immediately after, you're trying to flush. So on my residency, we had a resident, and they tried to push the adenosine because we were trying to see if we could. They wanted us to see how it looks for a patient to get cardioverted. And this person had PSVT, and so we were trying it. And so they gave the 6 milligrams, and they flushed it, and the patient was still just looking at us. And so the doctor, he was like, oh, thanks for giving me the meds. Because we give them medication before because it doesn't feel good for your heart to stop working. And so if you're going to be a nice provider, and if you have time, because sometimes you don't have time, If you're a nice provider and you have time, you can give them like pain meds, lidocaine, things like that to kind of help them calm down a little bit. We diazepam or something to just calm them because you're about to do this procedure. And then sometimes we'll use fentanyl or something like that to help with the pain. But he's like, oh, thank you for the meds. Like, this wasn't that bad. And the doctor looked and he's like, it didn't work. We're going to do it again. So the first one that we did was the 6 milligrams. It was not effective because it took too long for the flush, or it could have also been that the patient just didn't feel it. So then we increased it to the 12 milligrams. We waited a little bit, so that 2 minutes, increased it to the 12 milligrams, and then we had the flushes right there, and they flushed right after. And the patient was like, ooh! And I was like, oh my gosh. He essentially died, right, and came right back. And he was like, oh, that hurt really bad. And I was like, oh. And the doctor was like, okay, so that's what you should expect to hear. And if you didn't give him anything at all, it would have been a lot worse, like how he responded to it. Okay, so this is the quick on, quick off. So light switch, like you're just trying to reset it. Adenosine is like quick, okay, in and out. So this is what we were expecting to see, right? He flatlined. There was nothing on the monitor. Because we wanted to reset, we turned off the light and then we turned it back on again. We turned the heart off, we stopped it from beating, and then we turned it back on again. So this adverse effect is what you want to see. You want to know that your drug worked. The tightness, the pressure, the burning, right? His gasping, all of these things are what you are experiencing if your heart stopped working. I'm terrified that my heart is not beating, right? Anxiety, all of the things. He didn't experience flushing, but you also have flushing here. And then your interaction, just remember with theophylline, it's possible that someone's on this drug. We don't use it a whole lot, but it is possible, okay? So remembering super short half-life, you have to follow it with that flush because you got to get that amount in there. You start with 6 doesn't work, you wait that 2 minutes, wait a little while, let that person kind of recover, okay? And we don't know what else is left in the line, so we don't want to mess with trying to overdose the patient, right? That off is a little delayed, we don't want it to be our fault, okay? So you wait that 2 minutes and then you hit them with 12, so you doubled it. And you hit them with the 12, bless you, and that should work for them, okay? Nice provider, nice PA, pre-treats them. They give them something for their anxiety, they give them something for the pain and the burning, okay? If you have time. Mag sulfate, we've seen this before when we were talking about preeclampsia, eclampsia, and trying to prevent those seizures. You can see it here, also used for torsades. So neuromuscular blockade is essentially what's happening. Remember, when we think about calcium, calcium makes things contract, it makes it work. So if I am now trying to compete with that, I can decrease that amount of excitability, which is what I'm wanting to do. So if I'm a neuromuscular blocker, that means I am calming down those contractions that are happening. You see some vasodilation that occurs. We don't typically use it in this sense, and then you see the CNS depression that could happen, and that's what we would want if somebody had a seizure, right? We want to calm down all of that electrical activity that they're having in their brain so that they stop seizing, they stop convulsing. And we also get the benefit because it has that neuromuscular blocking. I can try to relax things down on several fronts. So torsades, preventing seizures, when we talk about our eclampsia, preeclampsia, hypomagnesemia, right? They have, hypo is low, so I don't have enough, so I can give them IV for that. Asthma, haven't seen it used for this. And tocolysis, also haven't really seen it used for this either. So mainly these three up here at the top are typically what I have seen it being used for. PK parameter, because it is IV, and remember that it's IV, and remember it's mag sulfate, because you also have mag citrate and all the other magnesiums that we have talked about when we're looking at GI things. This is not the same thing, okay? So pay attention to the fact that it's mag sulfate and we have an IV and IM formulation, which is why we don't have any oral routes that we can use for this. Looking at your adverse effects, I told you that it vasodilates in the mechanism of action. So you see the hypotension, the flushing, all of those are a result of the vasodilation. And then more serious things that you can have happen is some heart block or cardiac issues to where we have prolonged the QT so much that it could be harmful. So you don't want to overdose them, give them too much magnesium to now you've overcorrected and now they have hypermagnesium. And remember, your magnesium is dealing with the conduction of your heart, right? We have magnesium, we have sodium, and we talked about what other one? K, yes, potassium, right? So all of these things are very important electrolytes that we are looking at to say, hey, I don't want to mess with this because if I throw them off on here, I throw off my orchestra, the synchronicity. I don't even know if that's a word. I throw off my heart being in sync and beating correctly, okay? My interactions, so monitor your electrolytes like we already talked about. And then my interactions, anything that can also slow the heart rate down, right? So my calcium channel blocker, non-DHP, my calcium channel blocker that is not non-DHP, because remember those DHP calcium channel blockers are focusing on vasodilation. We use those a lot in hypertension. So if I have those on board with my IV magnesium, I could tank my patient and drop their blood pressure quite a bit. Okay, so that's an additive effect. Then you have your digoxin, the increased risk of those arrhythmias. And then because I can depress the CNS with this, right, my indication over here, my mechanism of action, if I have any other drug on board that also does that, now I have additive effects. So your big issue here is additive effects all the way around. Any calcium channel blockers are a problem for you, whether they're DHP, non-DHP, your digoxin, and your CNS depression. All right, arrhythmia treatment. So we talked about arrhythmias. We said, hey, I have to talk to the patient to see what the patient wants. Do they want to be in sync or do they not? Some people are fine, they don't have any symptoms, and their heart is just marching to the beat of its own drum, okay? And they're okay with that. There are some people who are very symptomatic and they are not okay with that and they want to try to cardiovert. So this is us looking at cardioversion, right? I told you we had the mechanical where we shock them, or I can give them different drugs to help them, okay? This is just showing you different types of classifications. All this other stuff, you can skim over it. Lots of people have AFib. Lots of people have arrhythmias is what this is telling you. But you have different classifications. So you have paroxysmal, persistent, long-standing, persistent, permanent, and recurrent. When you look at your paroxysmal, this one is essentially saying that a patient could be walking around and all of a sudden, and they're in AFib, but all of a sudden their body converts and they're not that way for over a week. And their body converts itself back into normal sinus rhythm. Okay, so paroxysmal, most of the time you're not going to really see that unless somebody just so happened to come in for a checkup and you just so happen to catch them in AFib. Persistent is for somebody that's lasting over a week, so over 7 days, whereas your long-standing persistent is a person who's greater than 7 days but less than a year. Okay, so that's your long-standing persistent. And your permanent is your patient who they may have tried to cardiovert or they tell you that they don't want to cardiovert. And they got back out of that normal sinus rhythm. This is a permanent patient. And then you have your recurrent where it just, again, it keeps happening to them, right? So 2 or more is what we would see there. So just be familiar with there are different types, okay? These are your different types. Now, told you this already, we have electrical, like our mechanical, us shocking them, or chemical cardioversion. So when you see AF in the slides, that's referring to AFib. When somebody has AFib, they have been diagnosed or you have diagnosed them with AFib, there is a decision that needs to be made by you and the patient. So are we going to cardiovert you or not? Okay? If the decision is, no, I don't want to be cardioverted, you leave them alone. You can try to give them things to help with their symptoms if they experience symptoms. We can have the pill in the pocket approach for them to use. These patients who usually say no are used to slipping in and out of AFib. Okay, so their body is just okay. If they have been experiencing AFib for longer than 48 hours, you need to make sure that they have not had some type of clot form. So AFib, my heart is not beating like this, how it should, and moving my blood, right? So I'm not pumping correctly. AFib, I could be like doing a little quiver, and I'm still pumping, but I'm quivering, but I'm not squeezing all the way. So now there's blood that's being left behind in chambers. Sometimes maybe not even disturbed. So with that, now I have clotted right? Because I'm sitting there. Now we're friends. The blood becomes friends, and now you could potentially form a clot, all right? When you try to cardiovert them or get them back into a normal sinus rhythm, you can throw that clot that formed. So that's what I was talking to you about yesterday. So you might need to anticoagulate your patient. Remember, coagulation means that I have bonded together as the blood, right, and I made a clot. So if I anticoagulate, I want to break that up. I want to anticoagulate that person before I get them back into normal sinus rhythm so that there is not a clot that they're going to throw, okay? So anticoagulation would be recommended. We're looking at that once they hit that 2 days. Some patients don't know how long they have been in AFib. So your best bet is to make sure that there is not a clot, right? If I don't know, we're going to be very careful. So anticoagulation might be recommended. So before you cardiovert, you need to make sure that there's no clot there. So there's no thrombus, okay? No thrombi that are present. So you can do 2 things, and these are very different things. You can do a TEE, transesophageal echocardiogram, to look in the atria to see if there is a clot that has formed, but this is an invasive procedure, okay? The patient has to come back to the hospital. They have to get this performed. Some people will tell you, I don't want to do that, okay? But you have another option. They can just be anticoagulated with oral medications for a certain period of time before you cardiovert them, okay? So our meds would take care of it. It's just not as quick. And they don't have to come back, okay? So this is an option. So you have to do one of these 2 things if it has been over that 48 hours, okay? One of them is a must. TEE, invasive, anticoagulation, not invasive. They're just taking some tablets, okay? This depends on what guidelines you look at. Some people will anticoagulate 3 to 4 weeks prior to then performing the cardioversion. And then after someone gets cardioverted, because they could slip back into that abnormal sinus rhythm, we also anticoagulate them for a little while afterwards. So this will be guideline directed on how we continue to monitor and change this, and y'all will learn more about that in cards. So these are the different therapies that we have that could potentially affect cardioversion for a patient who is in AFib. So we already talked about all of our things that dealt with rate control. So we have our beta blockers, we had our non-DHP calcium channel blockers. Remember the difference, non-DHP versus your DHP. And then we also have digoxin. These were the things that we were using to help control those symptoms. Now, I could use my beta blocker or my non-DHP calcium channel blocker by itself to control those symptoms, but let's say I'm still not having great symptomatic control. What could I do? I could add on digoxin to help. Remember how I told you earlier, we don't usually use digoxin all by itself for the most part. Digoxin has all of the things that we were worried about, the halos. We have to monitor it, narrow therapeutic index, right? These I use for so many different things. My beta blockers, my calcium channel blockers, non-DHP calcium, I can use them for so many different things, okay? So this is helping with symptom control, all right? These first 2 can be used alone. Your digoxin can be added if you're not getting the result that you are expected to see from your beta blocker or your non-DHP calcium channel blocker. Now my rhythm control, we've seen these before, right? We kind of talked about them before and how we used them yesterday. So now to actually change the rhythm, right, because this was my rate, but now to change the rhythm, bless you, and get them back into a normal rhythm, I can use my class 3 antiarrhythmics. Amiodarone is in there. Amiodarone is just one of the ones that we like to use the most. But remember when we talked about amiodarone, it had a lot of stuff, a lot of work, right? But it is a great drug. It's a very effective drug. So you can use my class 3 meds, or I have my 1C meds that I can use, okay? Does anybody remember my 1C meds? Fries, please. Remember, we were at McDonald's because we're in class 1, right? We ordered our quarter pounder, we had lettuce and mayo, and we had fries, please. Don't just remember those letters that I told y'all, because there's lots of F's and P's, okay? So when we look at that, we had our flecainide and our propafenone, okay? So remembering what drugs we're using for what things are going to be important, because that's how we're cardioverting, or getting our person back into that normal sinus rhythm, okay? And then afterwards, and potentially before, because remember I have an option of doing a TEE, or I can do my anticoagulation with my DOACs, and we'll talk about that, and y'all are going to learn that a little bit later. But I can anticoagulate with aspirin or an oral anticoagulant, and we'll talk about this. But I do that before if they don't want to do the TEE, and I do it after, because remember, after I cardiovert them, they could slip out of that normal sinus rhythm that I got them back into, and now they're at risk again for those clots. So we just are safe, and we treat them prophylactically after they have that cardioversion. We good? Next door, we good? Okay. All right, so symptom control, not used by itself, helping us get our beta blocker, calcium channel blocker, to where we need it to be, because our symptoms aren't controlled alone with either of these. And then looking at my rhythm, I have a class 3 antiarrhythmic or a 1C that I could use to help my patient get back into a normal sinus rhythm. Anticoagulation can happen before or after, okay? And or after. All right, so DOACs. This sounds foreign to you because you haven't learned about DOACs yet. So these are going to be our direct oral anticoagulant medications that we have. And again, coagulation, right? I made a clot. Anticoagulant, I am breaking that clot apart, right? I don't want that if I'm getting someone back in a normal sinus rhythm. So DOACs are superior to warfarin, and they are preferred. When we talk about warfarin, warfarin has a lot of monitoring. We even have warfarin clinics. There's a lot of work with warfarin, okay? And so if I can give a DOAC, I don't have as much monitoring. We like to not do a lot of work, right? Work smarter, not harder, right? So this is why we have DOACs. So your dabigatran, rivaroxaban, edoxaban, apixaban. These are examples of a DOAC. You will learn more about DOACs. I just need you to be familiar that these are names of DOACs. You see your dabigatran and everything else ends in a ban, right? A ban. And dabigatran is the one that is like your outlier that doesn't fall all the way into that, okay? Warfarin, you have to manage it. Lots of things that could change it, including their diet and how they eat. You have to make sure that they're within a correct INR, that they're not bleeding out or internally. Lots of things with warfarin. So you see here that I can potentially, if a DOAC can't be afforded, or there's a reason why they can't take a DOAC, because there are contraindications, which we'll talk about next block. I think it's next block or the fourth one. One of them. Y'all will talk about it. But you will see that lots of things end up coming into play. So you have warfarin. You also have heparin, very rare. Lots of monitoring again with heparin. And it's an injection, so that becomes a little bit more difficult for the patient. And then you have aspirin, not as effective as our DOACs, so that's why these are a lot smaller. See how I made them small? That was on purpose. But you have DOACs and warfarin that could be something that you use. When we talk about using warfarin, you're using warfarin if somebody has moderate to severe stenosis or a mechanical valve, or for whatever reason they can't afford it. Let's say they didn't have insurance, right? We're not in the perfect world. So these are the reasons why they would be excluded from using that DOAC, and this is those patients that would benefit from warfarin, okay? So DOAC number 1, warfarin number 2, only in these situations. These are options, but not common, so I'm not going that far down. Now, we have what's called a CHADS-VAS score. When you see the CHADS-VAS score, this is a scoring system when somebody comes in and we are trying to say, hey, what is the chance of them potentially having a stroke, right? So anytime you see AFib, you need to go and do a CHADS-VAS score. I am expecting for you guys to remember all of these things that are on here, okay? I'm just kidding. I'm not that mean. There are lots of calculators for this, right? So you would pull up a patient's profile and you would go in, oh, do they have CHF? Cool, they earned a point. So what you see is that all of these are essentially standing like your CHADS-VAS. It's an abbreviation or acronym for everything that we are plugging into that calculator. If they're greater than or equal to 75, they've earned themselves 2 points. If they've had a previous stroke or any type of issue like that, they got themselves 2 points. So that's why you see the 2, like CHAD 2 and then the S2, because those are the only 2 things that will earn them 2 points off top, okay? So these are just things that you would plug into a calculator, and it's called a CHADS-VAS score. I do want you to know the name that it's called a CHADS-VAS score, okay? So whenever we're looking at this, this is a male, right? He doesn't have on his dress. This is a male, and this is the female. I'm telling y'all because some people are like, I didn't know that was the man. It's on the bathroom signs, okay? So males, if they have 0, female, if they have 1, they don't have to be anticoagulated. They have a low chance, after I put everything in, I did my CHADS-VAS score, they have a low chance of having anything happen to them. If the man has 1 and the female has 2 for their CHADS-VAS score, I might have to anticoagulate them, okay? Consider it. Conversation. Equal to 2 or 3, 2 for the man, 3 for the woman, they need to be anticoagulated, okay? So 0, if somebody has 0, they don't need any anticoagulation. If somebody has 1, the man, maybe. Woman, no. She doesn't need it, right? That's also a maybe. Or sorry, no. If there's 2, then the man needs it. And if it's a man, then they need it. If it's a woman, then maybe. And then 3, no matter what, anybody can get it, okay? All right? Not me, it, an anticoagulant, a DOAC. All right? So remember this, because this is very important on how you're going to anticoagulate our patient, right? And we want to make sure that we take care of him. This was just talking about, again, what we already said about digoxin, not usually monotherapy, something that we're adding on to that calcium channel blocker or my beta blocker to get my patient to where they need to be. Avoiding in our patients who have that WPW that we talked about, right? That extra pathway. Usually those patients are going to be tachyarrhythmic, but we're trying to avoid our digoxin in those cases. This is a repeat of what we have seen before. So you have your beta blockers, and this is just telling you, again, specifically what you can do with a beta blocker. So when you're looking at somebody who has heart failure, right? Remember we had decompensated, which means they're not stable at that point. Or we can have somebody who is stable, but they have heart failure, okay? But I manage, you have me on my meds, I take my meds, my injection fraction is not great still, but I am stable. These are the specific beta blockers that you are going to look at in those patients who have stable heart failure. Carvedilol, metoprolol, this is important for metoprolol. Metoprolol, we have immediate release, but we also have controlled or extended release as well. We need controlled or extended release in this situation, not immediate release. Immediate release is not going to do it for them. And then you have bisoprolol, okay? Same adverse effects that we talked about. Looking at our non-DHP calcium channel blockers, if somebody has systolic dysfunction because of the mechanism and how the drug works, and they potentially have heart failure, we're gonna, again, try to not use these medications because now you're just it's an additive effect. You're worsening the symptoms that those patients are experiencing. When we look at this, because we talked about beta blockers, right? And remember we said that beta blockers could cause a bronchospasm in patients who have asthma. That's when you could potentially see your non-DHPs as being beneficial, okay? Because this could trigger my asthmatic patient. But in this situation, we could see where, hey, this one might be a good benefit for me, my non-DHPs. All right, your 1C. We talked about our 1C, right? Flecainide, propafenone, without structural heart disease, okay? We'll talk a little bit more about structural heart disease in a minute, but you have your pill in the pocket approach that we talked about already, right? I keep it in my pocket. I don't keep it in the car because now my meds might not work properly. And then looking at your contraindications that you have, anyone who has structural heart disease, contraindication. because I already told you your 1C are without structural heart disease, okay? So if you see somebody who has structural heart disease, can they use 1C? No, okay? If I tell you your patient has structural heart disease, they can't use these. They're out because it is a contraindication. Contraindication is telling us no, right? These were the ones that we also talked about with the CASH trial where they were pro-arrhythmic, right? So we were also still worried about that. So that gives us another reason as to why we don't love to use those. Class 3, amiodarone. This one is a big one that we like. Again, I don't tell you doses often. This one, just know that there's a huge loading dose that we have. So a loading dose of 10 grams. So this is what I was telling you about before. You have a choice to pick either an oral option, which sometimes if our patient is okay, we would prefer that so that we're not giving them so much fluid. And they're in a hospital bed and they're sitting down and now I'm causing edema and several other issues that could potentially happen. So loading dose, we like to do that orally. The big thing for you to make sure of is that the patient is following the taper that they're going to be on, because their maintenance dose is not the same as their loading dose. Remember, my loading dose is helping me get within that therapeutic window quicker, and that's all it is a boost, okay? Once I get to that loading dose, once they reach that 10 grams, their maintenance dose changes, and they're just taking the 200 milligrams every day. It's not these huge amounts that they're taking, 400, 2 to 3 times a day. It's not that much. It drops down. Patients forget this taper, and some of them will continue to take their amiodarone several times a day after they've been loaded, and now we have more side effects that are happening to our patient, right? So make sure that if you see amiodarone on, that they're in that maintenance phase, that they're usually just taking it that once a day. See your pros and your cons here. Just look at them. We already talked about them. But a big thing that we do see here, like we couldn't use our 1C in our patients who had heart failure, our amiodarone, we can use those, okay? I mean, we can use it in heart failure. Your dronedarone, sotalol, dofetilide, ibutylide. These are more of those class 3 agents that we have. This is just telling you the efficacy that you see, remembering when I need to go to the hospital, my sotalol versus my dofetilide. And then you also have ibutylide that is an option. Again, this one, they want to make sure that we're monitoring the patient afterwards to make sure that it doesn't cause the proarrhythmia that could happen here. So remember, big things here, the same things that we talked about on the individual slide was the how much we can benefit from these, as well as hospitalization. Which ones require hospitalization? If I tell you I don't want to be in a hospital, that knocked out 2 of them, right? So now you only have dronedarone and ibutylide that you can use. And again, these are specifically talking about cardioverting our patient, okay? Your heart failure. These are different things that you can see used when we're talking about heart failure, so pay attention to the bold. We've already talked about what we were avoiding, okay? So avoiding our class 1A, 1C. Remember our 1B were more for like pain, the lidocaine and the mexiletine. We didn't really use those a lot anyway. But you have amiodarone, dofetilide, sotalol. These are the ones that we found that have a neutral effect. You'll hear kind of back and forth on sotalol and using it in HFrEF. Y'all will get into that. But for this, just know that it is a special population that you could potentially use the sotalol in. Dronedarone is a no, okay? If my patient has heart failure, dronedarone is contraindicated, okay? Then looking at your MI patient. Again, 1A, 1C continues to be your problem, right? I see my amiodarone and dofetilide are 2 potential medications that I could use in that situation, okay? So pay attention to what the special issue is, heart failure here, MI here, what drug can I use in that situation, okay? If my patient presents with that and I'm trying to cardiovert them. This is an algorithm showing the same exact thing. So when we talk about structural heart disease, essentially what we're saying is like any condition that can affect the heart valves, the chambers, the walls, the muscles, like any part of the heart being affected, that is when we are saying that it is structural heart disease. Otherwise, no structural heart disease. So this is, again, a recap of all of the meds that you can use. You see your amiodarone there being one of the ones that, great drug, lots of loading, so that's why this one is kind of down there. And again, this is an algorithm that can change based on the guidelines, so whenever you're out in phase 2 you shouldn't be having to really do this in practice, but phase 2, you might have somebody that wants to talk to you about it. Just look up the most current one or ask them what guideline they want you to look at for that. And then structural heart disease. So if I have CAD, my artery disease, or if I have heart failure, you see that there's 2 different pathways that you're going down. So when I see my coronary artery disease, I have dofetilide, dronedarone, and sotalol. And remember I told you couldn't use dronedarone in heart failure. Again, depicted here, amiodarone and dofetilide. And then we have ablation. I'm not going to ask you about ablation because it's not a drug, it's a procedure. You go in and you try to terminate those extra I'm not asking you guys that. Anytime you see an actual procedure, I won't ask you that. I will tell you if I'm going to ask you about a procedure. Okay? So this is just telling you like, hey, this didn't work by me doing it chemically. Now I'm going to go in and change something, like do a procedure, if that patient wants to do that, to ablate for them. So not something that has to happen. What else do I want you to know from here? So pay attention to this, please, because this is a summary of what you kept seeing the entire time throughout. All right, 65-year-old male presents to clinic for drug monitoring. He's taking amiodarone. What should you perform? All of them, right, at baseline. Remember, amiodarone all over the place. Lots of things that we have to do. Most of our follow-ups happened at how many months? 6 months, most of our follow-up for these things. So make sure you have it at baseline. Most of them were 6 months. Visual, you can check at any time if a person is telling you there's something going on. Same thing with Pharm. Now, if something is out of whack, don't say, well, you haven't hit 6 months yet, you gotta wait. Check it, okay? You don't have to wait. That is the recommended, all right? This is just a summary slide telling you all of the different types of arrhythmias that somebody could have and the drug of choice for that. So for a bradyarrhythmia, you have atropine, which we didn't go into a lot of detail about, so make sure that you're looking at this mechanism of action for atropine. We talked about this in Pharm 1. I'm pretty sure that was like 10 years ago for y'all at this point. PSVTs, we talked about this, right, on and off. My light switch with adenosine, so we talked about that mechanism of action as well. There's other maneuvers that you can try, other meds that we can try. Just focus on the fact that we have this for PSVT, so you're bolded. Ventricular tachyarrhythmias or pulseless. Remember I told you the pulseless and with a pulse, without a pulse, that makes a difference on what we're trying to do. This will change based off of our BLS algorithm that we have. So you will see some of these come in and go out of favor. So I want you to focus on your drug of choice. I'm not going to ask you about your alternatives here. So again, look at your drug of choices that you have. You have epi, and you also have amiodarone that you could potentially use for torsades. We talked about that magnesium. Remember that a lot of our drugs that we talked about in this block could also cause torsades, so be careful with that. And then again, a recap of your mechanism. Don't worry about the dose of the magnesium. I'm not asking you that. I used to. And then these are some FYIs for you to look at later, but these are a lot of the drugs, and it's a recap if you want to see them all on one, because they are individually put in the slides on what we have for torsades, but this is for you to see on one side. I love the slide because it's just easy and it goes across a lot of the things that we've already talked about. So again, this has the summary of some of our antiarrhythmics that caused it. We talked about our fluoroquinolones and our macrolides potentially causing torsades. These were our medications for nausea, antidepressants, psych meds, and migraine meds, which y'all are going to talk about as well. But just keep them in mind as y'all look at this in your starting practice in the real world. All right, what do we know? What class of antiarrhythmic is lidocaine? 1B. What else could we potentially use lidocaine for? Pain, right? And then, is this good orally or IV? IV. What was the option that we had for oral? That was 1B. That starts with an M. Mayo. Mexilotine, right? That was the one that had the good oral bioavailability. All right, true or false? Sotalol initiation needs to be in the hospital for a week. How long do they need to be in the hospital? Up to 3 days, right? We need to make sure that we're monitoring them 1 to 3 days, but 3 is safer. How is adenosine pushed? What do I give them first? How much? 6, flush. And then what if that didn't work? 12, flush. All right. So 6 followed by the flush. Got to be fast. Super short half-life, seconds, right? And then your memory jogs are here. All right. So tomorrow you have arthritis and gout. Class leaders, y'all can move up. If y'all have another class, you can move it up. I'm done. Arthritis and gout tomorrow. And then you guys have a while to study for your exam. I will be around if you have any questions. I won't be in the office tomorrow after 12 because I have our Houston visit. So I will be back on Monday. All right? Let me know if y'all need me.